Okay, hello and welcome to week 4 of the Level 3 Health and Social Care, Unit 307, the Dementia Unit. And we'll be looking at 2 sets of slides for this week. And the sets of slides we're looking at the moment is we'll be focusing on treatment and support for users at the end stages of dementia. So the objective for your assignment that we'll be focusing on is 3.3, explain the treatment and support available for service users at the end stages of dementia. Okay, so let's think a bit about planning for end-of-life care. When a person with dementia is approaching the end of their life, it can be a really difficult time for them and for the people around them. However, it's important for you to know as a professional carer that there are things you can do that can really help support the person and also support their family as well. And one of the things that really helps is having really good communication between all of the people involved in the person's care. At this time, you may be bringing in some other health and social care professionals at end of life, specialist nurses. There may be pain management doctors as well, particularly. So communication is really important. If you're allocated as the person's key worker because maybe you work in the care home where the person lives, then it's really important to make sure you've got good open lines of communication between you and other people. Why is planning important? It's so that we're not so reactive. It's so that we can be prepared for things, so that when new things have to be moved into place, it can happen sort of smoothly rather than jerkily and reactively. And for a person with dementia, it's important to try to have some conversations a bit earlier on in life while they're still able to make some decisions. Now, that's not always easy because some people don't really want to think about, their dying time. And in this case, if they haven't been willing to put plans into place, it's really important that somebody who really knows the person well and who knows what their values, wishes, and beliefs, what's important to them, what's not important to them, particularly about sort of spiritual requirements, things like that. That can be really helpful when you're making decisions together with the family. But again, it's very important to try as much as possible to think about what decisions can be made um, ahead of time, and that really includes thinking about housing options. You may well have been supporting someone in their own home, and you may decide, you may sort of want to think for the future. Would they want to go to a care home? How long would they like to be supported? Um, if they are going to a care home, where's it going to be? Think about the needs of the family, stuff like that. So that when you find out that people are deteriorating, you can sort of put these ideas into place in a smooth way. What is palliative care? Have a little think about it. Do we know what palliative care is? If you're not sure, you can maybe look it up, or just take a moment to think about what do you know as palliative care. It's for anybody who's diagnosed with a life-limiting condition, and that includes dementia in this case. It could be other illnesses, motor neuron disease, MS, those sorts of things. It focuses on making a person's quality of life as good as possible. And the idea really is to relieve discomfort and distress. So it's about making people comfortable as well as you can. Someone can receive palliative care for any length of time. So it could be for several years, or it could just be a few days or weeks. And it can be offered alongside other medical care, especially in the early stages of dementia. And in the later stages of dementia, you will be looking at end of life care where you might be doing some very specific interventions. But that palliative care, the making people comfortable, relieving distress, will go alongside of it really. So what is it? It focuses on three areas really: physical, psychosocial, and spiritual. The physical stuff is about relieving pain, managing people's symptoms as best you can, and trying to deal with any discomfort. The psychosocial is looking at emotional and mental support, trying to fulfill goals that the person might have identified that they want to do before they die, maybe. Or they may be small, they may be big, working through those sorts of things. If they have spiritual needs, finding them a purpose, giving them empowerment to make as many decisions as they can, or be as involved in their care as they can, even if it's only on something as simple as choosing what they're eating to, choosing where they're going to stay. And really to give people closure. And that not works just for the individual, but also for the people who are very emotionally tied up with them, like family and friends. Is it hospice or palliative care? No, they are two separate things. They're often provided by two separate services. Hospice care really focus on anyone who's got a terminal diagnosis. So they've usually got a life expectancy of 6 months or less. It's very focused on helping people through the dying process. Palliative care can be anyone with a serious illness. It's about making people comfortable, even if if there's no cure for the illness, it's about finding ways of being comfortable. Where they are similar is in this making people comfortable, trying to make people free from pain and trying to avoid distress. But palliative care, if there are curative treatments, they can be given alongside. We're in a hospice when someone's making the decision to go into hospice care, they're not looking for curative treatment. The curative treatments will not be functioning for them. So it's generally about the full-on palliative support, really. Where can it be provided? Anywhere. Hospice care can be anywhere the patient considers home. Very often they can go into a specialist hospice um, or assisted living facility, or some of them can still actually take hospice care from home or in their own home. And it's the same with palliative care as well. So moving on from the palliative care situation, we'll start looking at what is end of life care. So it's really aiming to support the person in the very later stages of your life limiting condition to live as well as possible until they die. So in the case of dementia, we'd be looking at supporting people through that third stage of dementia, which is a deteriorating process. But the aim is to give the person to die in the way they would have wanted, prioritizing the things that matters to the person, which is why it's really useful to get those sort of ideas and wishes beforehand when they're able to discuss it with you, so that you can put the right plans in place. And it's also is a huge amount of focus on supporting the family and their informal carers during the final stage. Can last for just a few days and it can last for a few weeks. More often than not, it's weeks. But for many people, it could continue for months or even years, unfortunately, in that sense. So, how would we support a person with dementia with end of life care? We really need to have a look at someone's physical needs, pain relief, management of any other symptoms. We need to look at their emotional needs, especially managing the distress or fear or other forms of distress. We we need to look at their relationship with others, who they want to be there, who they don't want to be there, people they want to be visited by, people they may never wish to see again. You need to sort of respect some of those sort of things. The environmental needs, how they want their room, what sort of music, what is comforting to them? Is it dark? Is it light? Do they, do they want all their favorite things around them? What are their cultural needs? Making sure that those areas are particularly met during this time, because it might be difficult for them to often say what they want. What input do they want for their spiritual needs? Some people may want no input, so it's important then not to foist maybe some, a spiritual advisor on them if you know that throughout their life they've never wanted it. Um, on the other uh, on the other case, if someone is follows a particular religion, like, so they may be Jewish, they may follow Islam, then to make sure you get the right people, and that's you're usually able to reach out into the local community and find people who can help, no matter what the spiritual need is. And here again, advanced care planning can be really, really helpful. Dying well. So, what does that mean for a lot of people? It often means being treated with compassion and respect. It often means, being kept clean and comfortable, and as free as much as possible from your symptoms, or you're just getting symptoms to be reduced as much as you can. It often involves being in a place where people are familiar. It's not always great to move someone to a strange place during this process, because that can cause them quite a lot of distress. And also being surrounded by those that are close to them, so encouraging family and friends to come up, spend time with them, and also with staff that they've got to know and work with. So maybe if someone is in that stage where we know end of life is quite soon, if there are particular staff members that have always got on very well with, they have a good rapport with, maybe allocating that staff member on a regular basis to them so that they can talk to them and sort of feel reassured. Doing lots of little things for the person can help a lot. Sometimes it's just about reassurance, talking to them. Sometimes it's the simple things like brushing their hair or just holding their hand, letting them sort of feel the comfort of your hand can can be really, really reassuring or take away some of the fear for them. So what would you do as a professional when you're managing end of life care? First of all, you need to be doing, the person should have a risk assessment anyway, but when you move into that stage, your risk assessments need to be updated. You need to identify, you need to focus on the things that could actually make someone's quality of life worse. So what do you need to change? What do you need to avoid? As a carer, it'd be your responsibility to keep families updated, because things could change quite quickly. But you need to make sure you've got all your contact numbers and that you're speaking to them regularly. The care plan needs to be reviewed and updated to sort of pick up the end of life plan. And it should be shared with all those involved. Picking up people's spiritual needs, what their practices are, as I've mentioned already, they need to be addressed, and they're just as important as your medical interventions, really, because that can cause people a great deal of distress if the spiritual needs aren't aren't being sort of listened to, and they can provide a huge amount of comfort. It could be just having some religious objects around. It could be having the local vicar pop in and sit down and pray with someone or do some readings for them. And they're quite used to this, so you need to give them time to organise themselves, but they will usually make themselves available. Signs of the dying process. As someone's condition gets worse, and they're in a few hours or days of dying, changes. There are changes for you to look for as their professional carer. They start to deteriorate more quickly than before. They may well lose consciousness. Sometimes they regain it and then lose it again. So sometimes they may drift in and out of consciousness. Their ability to swallow a lot will often reduce. So you need to look out for that, because the last thing you want is them choking. So you need to be a little bit quite alert to that. They could become agitated or restless. They'll develop an irregular breathing pattern, and that's something very, very important to look out for, because that gives you a real clue, really. Their extremities will become cold because the body's not managing to keep everything working. So it will focus on the vital organs. So feet and hands will become very cold. They have a sort of chesty sound to their breathing, like when someone's got quite a bad chest infection, and you may not have had that before, but when you start to hear it, and there's a particular rattly sound someone's breathing. I think it's hard to describe, but once you've heard it, you'll sort of remember it forever, really. And that's when people are really close to the end. The person can often be actually unaware of this process. They can be unaware they've hit this stage. I mean, you'll be able to observe it, but they might not. So just be aware of what you're saying and doing to them. Even when they're in and out of consciousness, they can often hear you. So just think about not causing any distress. What can you do to help? This is when you really need to give the relatives a lot more support. This is when you need to explain each individual change so that they can understand what's happened. You can even tell the relatives what they should be looking out for. The other point to do is to try and really, really focus on managing pain. The last thing you want is someone to die in pain if you can help it, if you could avoid it at all. If the person can't swallow, um, or they can't swallow tablets, there's lots of things we can do now. There are fluids, there are skin patches you can give painkillers on. They can even have syringe pump drivers, as you see here in the image, that provides flow of medication, which you can control, or they can actually control. Sometimes, if you think they're able to, they can bump it up. Otherwise, you can control it. Um, so you would need a professional pain doctor might step in. Now, your GP may well be qualified to do that, or there may be a specialist district nurse who can help manage those and oversee that with you. The relatives will be sort of part of the discussion, but the district nurses often sort of lead that. And they will come into you just to check all the equipment's working, and then you will get everything written up. So you'll be dealing with controlled drugs then, and then there's a little bit of legislation that you need to understand that your home manager will tell you about. If you're in a home that's got some nurses managing it, they'll sort of take over that part of it, really. Communicating at the end of life. Persons likely to have problems with communication in these late stages of dementia. They may already have sight or hearing problems, and there will come a time when they may well hardly communicate as maybe as they used to. And it can really make it difficult for you to know whether someone's in pain or not. So there are ways that you need to keep up communication. Think a lot about body, facial expressions. Make notes of them. They they may still be aware of what's going on, even if they can't speak to you. Be careful about loud noises, loud music, that sort of thing. It can become quite distressing for them. So just try to be aware of that. But don't rely on words. Really think about your gestures, your body language, your facial expressions, and some very gentle touches. That can usually help you. Keep the language that you are using fairly simple, fairly straightforward. You could get them to squeeze your hand for yes or no, if that's what you want. People can often manage that. Stay really close to the person. Don't tower over them. If they're in bed, they often are in bed at this stage. Sit down next to them, or sit on the edge of the bed, or just sit in a chair next to them, so that you can actually like look into their face. Give them lots of eye contact, so you can see any changes in expression when you're saying things to them. Look for signs they're in discomfort. Look for signs if their bodies flinch or if their shoulders hunch. As I said, getting them to squeeze your hand as a yes no is quite useful. And obviously the facial expressions they make. When someone's in pain, you can usually see it on their face. They'll usually be telling you one way or another. You can chat to someone, but just don't chatter on regardless without paying attention to see how they respond. But, some gentle conversation, maybe reminisce about some nice things that they've enjoyed, or, outings you might have done, things that you did with them, activities that they used to quite like. Do a little bit of reminiscence with them. Don't don't overtire them, but maybe just in a sort of lightly chatty way. When you are chatting to someone, just pay attention to how they're reacting to you. As I said, you could overtire them, and don't just sort of keep them awake just because you want to talk to them. Even if you don't think that they can follow what you're saying, continue talking to them. The tone of your voice, if the tone of your voice is soft and gentle, and non-panicky, or it can often help them to keep fear down, really, so they can feel a connection with you, even if they're not really having a proper conversation with you. Lots of physical contact, well, unless they don't like it. um, so holding hands, gentle touch, reassuring, touching people on their arm or shoulder, gently squeezing their hand, or maybe a touch on their face. Obviously, if it's something they really don't like, then don't do it. But otherwise, do it. There's something called Namaste Care, which is something that's done in quite a lot of care homes nowadays. It's someone's been living in a care home. A lot of care homes bring this in. It's about offering social and emotional support through gentle activities. I've given you a little Namaste poster here. You can have a look on Google to find out a little bit more about it. And they would sort of do things like gentle massage, putting moisturizer on people's skin, because often people's skin gets very, very dry when they're in bed as well. But the actual movement, the massaging, a bit like going for a facial, like a luxury facial, washing people's hair for them, or brushing people's hair. People actually find that quite therapeutic as well. That sort of thing. Maybe if they like animals, bringing a cat in for them, or a dog in, if that's what they like, to pet, really. Playing favorite music, or maybe reading from a book that they're interested in, so that they can actually hear the words, is good. um, Putting together, you can actually get the families to put together playlists of things that the person really like, or you might even be able to do it yourself if you know them very well. And they can have a little bit of music on just for a break, and it can help them reminisce a bit as well. Most important thing is, everything you do, don't do it too loud, because that can actually add to distress. So yes, play music, but be a bit conscious. If you feel that the music's getting on their nerves, turn it off for a bit. So not even if you love music, you might not want it on all the time. So you've got to really, really focus on the person, lots and lots of eye contact, and take your time. So people with dementia are at risk of pain. There could be lots of reasons for the type of pain, unfortunately. Could be just general arthritis, uh, bed sores if people are in bed for a long time, constipation, because unfortunately the pain medication ends up making people constipated, and they may be constipated anyway if they're not eating very well. Um, Being in bed for a long time puts you at risk of urinary tract infections, and they can be painful. Some people, for some reason, assume that people with dementia are less able to feel pain. That's not really true. Just because parts of their brain are not working, the pain receptors usually are. So, but they might not be able to let you know it, and they might not be able to sort of tell you where it's happening. So you've got to work it out as best you can. You need to be looking for signs and symptoms. So look at someone's behavior. Have they suddenly become distressed, agitated, or are they crying a lot, or can they not sleep? Think. Could they be in pain? Facial expressions, people will be making faces that look like they're in pain, or you can usually interpret those. Body language, they could be tense, they could rock. If they're fidgeting, can't lie still, or they might be clenching their fists, or pulling at the part, or rubbing the part of the body that hurts. So say if their hip's sore, they might well be rubbing their hip, or patting it or tapping it. Vocal sounds, well, if someone's in real pain, they will yell out, or they might, make groaning or moaning noises. Really, if you look at that, someone's probably in quite a lot of pain, so you need to react to it. Bodily changes in breathing. People tend to hold their breath when they're in pain, so they don't like to let it out. A high temperature or sweating, especially if they have got something like a urinary tract infection, because the infection will increase the temperature, start to sweat. So to see that, you think, oh, they could have a temperature. If they are in pain, again, you can get them to maybe squeeze your hand. Are you in pain? Squeeze my hand if yes, and they might be able to do it. So try that. We have a pain assessment tool here. There are loads of them, but this one is quite simple, one I've used quite a lot, really. If your communication is difficult, you can use this. So you've got, you can do 1 to 5s, 1 to 10s. This one's quite an easy one, 0, 1, 2. If you find anything more than a couple of these where you're going 1 or above, then you need to get some sort of help for it, really. If it's all 0s, fine. But if it's 1 or above, if you've got a lot of 2s, you need someone to come in really quickly and help you with some sort of pain management, because you've got some serious pain there. So you might need a specialist. So how can we support them a little bit more? Try to find out what discomfort is. It might not be as extreme as pain. They might have another form of discomfort. So sometimes it's think back to like when you had a child, maybe. It's the sort of thing where the baby can't tell you. You've got to try some of the classics. Are they hungry? Are they thirsty? Are they too hot or too cold? Do they want to use the toilet? Is the environment calm, or is there too much noise going around? And that can sort of get people very agitated. Could they be anxious or upset for another reason? Maybe the grandchildren have just visited and it might have, caused them a lot of sadness and upset. Doctors will treat pain, they will prescribe things for you, as I said earlier. And they'll start off with the mildest type of painkiller and then they'll work up. Because at higher doses, painkillers can have side effects, which can be unhelpful for the person. So they will tend to go up step by step, and they're only stopping where the side effects doesn't cancel out the use of the pain, really. Lots of ways to make people comfortable that can relieve pain, which can be some sort of gentle exercises. Lots of muscle massage can help manage pain if people are having pain because their muscles are contracting. Gentle massage and warming packs, where you can get these packs that you heat up in a microwave, a bit like the freezer packs, but you put them in the freezers, but you can also warm them as well. And you can put that on the area that's uncomfortable. So say if someone's got an arthritic hip and it's causing them a lot of pain, a nice warm pack, like almost like a hot water bottle, put on that area can be really soothing. So you don't always have to need drugs. Eating and drinking at the end of life. Take a moment before we go on to think about what problems could the service user have at this stage. Jot down some ideas. Think about how you might manage it. Let's see. Take your time, have a little think, and then when you're ready, so you can stop here for a moment, and when you're ready, go on. So it can be really distressing for yourselves to see that the person's not eating or drinking normally. Try to remember this is normal for that person, and it could be that at the end of their life they when they're unwell, they don't often feel as hungry as they probably used to. So you need to take that into account. And pestering people to eat sometimes can be too much. Obviously, you want them to eat enough to be healthy, but you might find out that you might have to sort of really reduce the size of portions, or maybe eat at different times as well. If they're struggling to eat or drink and they can't swallow, you might need to find other ways of doing nutrition. Now, you can have a nasogastric tube that goes through the nose and down into the stomach, or some people have a peg tube, um, goes directly through a hole in their skin. And they do take an awful lot of looking after. So they used to do it quite automatically for people, but they're thinking hard now that sometimes tube feeding is really not appropriate with someone with very advanced dementia. It is uncomfortable, and you sort of there's the management of it. The chances of it getting infected are often quite high, and a lot of people hate it, to be honest. So sometimes that you could say that it's actually going against improving the quality of life. Is it important they have a longer life or a better quality life, really? So they may well not do the peg feeding now. They may well um, just give maybe put a drip in to give people sort of glucose and things like that instead. Mouth care is really important. When a person is eating or drinking less, their mouth can often become very dry and sore. And it will be your responsibility to provide regular mouth care. You need to keep the skin around the mouth nice and moist so they don't dry up. And then if they dry up, their lips can become cracked and they can become sore. That's unnecessary distress, really. And because of that, they can also get gum infections, which are horrible. Mouth ulcers, that sort of thing. You can have sips of ice water, which can be really, really soothing, or you can actually rub an ice cube on some of their lips. That can be really helpful. Lip balms as well are used quite a lot. A nice lip balm. Sometimes the fruity flavored ones can be nice, and they can sort of, make someone feel quite a bit more cheerful. Managing infections. Unfortunately, the longer people are bedridden, they have a much higher chance of getting infections, particularly urinary tract infections, because they don't get up and move around quite so much, or they could get chest infections as well. This is if people are also not eating and drinking that well, dehydrating, or having problems swallowing. This can make it worse, really, in a way, because if nutrition's not good enough, then the body will not react so well to an infection. When should we use antibiotics? Well, it's a difficult decision, really. They have to consider each person individually. If someone's at end of life, well, you have to think about what are the antibiotics doing, really. Are they making somebody more comfortable? If there is a benefit to that, then yes, you could treat the infection. Do the side effects have any other complications? Would someone struggle to take the medication? Because if so, there's no point. If not, if there is, there's not much point giving it. How likely is it the person will fully recover if the infection is treated? And what does the person want? What sort of intervention does the person want? And this is where the advanced directives come really, really important. If they have infections that keep coming back, the doctor may talk to you about whether it's in the person's best interest to keep treating future infections. And if it means having to take someone into hospital to treat it, you've got to really think very carefully about whether you'd want to take someone from this, comfortable environment which they've maybe come to know and love, taking them into hospital when it could actually be their last days, really, into an alien situation for people they don't know, lots of noise and banging. because hospitals are like that. So sometimes you might think, well, maybe we don't treat it and just let it find its natural course. Each person is treated individually. There is no direction. It's got to be a plan, and usually a multidisciplinary decision as well, including the families. Unfortunately, delirium happens at the end of life, or if someone's already got a bit of delirium, it can actually get worse. They may become quite disorientated, easily distracted, they may become agitated or have difficulty staying connected with reality. They may well be seeing things, hearing things, or they might shut down and become very unresponsive. When someone's in the later stages, if they haven't had delirium earlier, it's quite hard to spot it in the late stages. If they've had delirium in the middle stages, then you're sort of used to it and you've probably already got your ways of dealing with it with that individual. So the symptoms of dementia can be quite similar to delirium, but delirium is something that comes on very quickly. Okay. Can be very distressing to the person, and it's treated very, very individually. And it depends on the causes. Again, it could be because of an infection, a urine infection. If that lies untreated for long enough, it can cause delirium. And again, if they can take antibiotics, you might be able to do that, or a couple of antibiotic injections might actually help to sort of reduce their distress. If it's something that's caused by something the medical team cannot treat, they may suggest using some sort of anti-anxiety drugs to help them calm down and reduce their distress. This is very individual, and again, this will probably be led if by the GP in the care home, or maybe by an external healthcare professional as part of a community team. But it will, again, lots and lots of discussion with a multidisciplinary team. And these sort of medications, these sort of calming medications, minor tranquilizers usually, can help to give them a bit more of a sense of peace, because you don't want somebody lying in an agitated state for the last few days of their life. So you've got to weigh up the swings and roundabouts. Using some tranquilizers can possibly shorten their life, because it can reduce their breathing, reducing their ability to breathe, their lung capacity. But you have to think about what situation do you want? Do you want someone to die agitated, or do you want someone to die comfortable? Okay, this is the final slide. I've just brought it all together, really. What is a good end of life dementia experience? It's having those good relationships. And when you're putting the care plan together, think about these sort of 9 themes, really. Basic care, a place like home, care for the caregivers, that's looking after the relatives and friends, being connected, communicating as best you can. Remember people's life and spiritual well-being. Try to preserve their identity. Try to remember their particular wants, needs, likes, choices. Don't suddenly turn them into a meat eater when they've been a vegetarian for 50 years. Think about things like that. Respecting them as an individual, but one of the most important is pain and controlling painful symptoms, really. Okay, so that's all we've got for today's session. Okay, I'll see you again in the next set of slides.